Hi everyone, I'm Dr. Rachel Matthew, the founder of All Things Women, an online platform geared to educating women and their partners on sexual and reproductive health. And in continuing our breast cancer awareness series, we're going to talk on breast reconstruction, recreating the new you. And we have a very special guest with us tonight. His name is Dr. Rajeev Venugopal, a consultant plastic surgeon at the University Hospital of the West Indies. He did his medical training at the University of the West Indies and completed his general surgery residency at the University Hospital of the West Indies and his fellowship at the Plastic Surgical Division at Jackson Memorial Hospital, affiliated with the University of Miami School of Medicine. Welcome, Dr. Venugopal.
Thank you, Rachel. It's a real pleasure and honor to be asked to do this.
Awesome. I'm so happy that you're here. So the breasts, they are not only important to men, but of course they're important to us women because it affects how we look in our clothing, affects our self-esteem. It just affects our overall appearance. And they come in different sizes, from small to very large. And as such, the loss of a breast because of breast cancer can be a very sad occasion for a woman, and it can affect her self-esteem. And I thought it would have been important for us to discuss breast reconstruction, especially for those women who decide to take that route in their breast cancer journey. So to not linger any further, we can get right into it. In a woman deciding in doing breast reconstruction, what are some factors she should consider?
Okay, so I think the first thing would be to establish how reconstruction can be done.
Mm-hmm.
So reconstruction can be done using your own tissue or using prosthetics, which is implants, to put it simply. So the choice is not available to every single person of which technique that they would prefer, especially when you try to use your own tissue.
Mm-hmm.
So that's going to really depend on the size of your breast to start off with, in comparison to the most common area we take tissue from is your abdomen or the lower abdomen. So basically, the reason we choose that area is that that's the area where a lot of people, men and women, will store a lot of fat. And as you know, 80% of your breast is fat. So whenever you reconstruct and you put your own fat, it feels very much closer to what a natural breast would be.
Yes.
So prosthetics, yeah, it's been improved over decades now, and each generation of implants is supposed to be better and safer, but it never quite moves or feels like the natural breast. So the choice of reconstruction will have to be individualized for every person after a physical assessment, basically. So then certain people may have, prerequisites in their minds, because if you're using the tummy, you have to buy into a longer operation, scars on your tummy, a longer recovery time. And some women just do not want, even though they have adequate abdominal fat to transfer, will opt not to do that. And there are others who will come with extremely large breasts, which may make getting enough fat from their abdomens challenging, or they just naturally have a flat abdomen. So it really has to be individualized from person to person. So the other big category about reconstruction is can be done immediately, meaning at the same time as a mastectomy, or delayed.
Mm-hmm.
So there's been a huge push to doing it immediate because of the benefits psychologically of less of a loss. It also saves on the amount of admissions to hospital, as well
Mm-hmm.
as, you know, there's obviously some economical benefit from combining the procedures,
Mm-hmm.
but that also has to be individualized based on how the patient presents in terms of how advanced the disease is. So in early breast cancer, we definitely think that combining the two, if the patient requests it, will be probably give you the best optimal cosmetic outcome with the least amount of downtime. However, there are some patients who we have to make sure that the cancer treatment is done without any delay. And in those situations, a delayed procedure is probably the safest. So I think just to put it simply, that would be the two categories that people would have to kind of have a understanding about.
That answered my next question concerning how soon is too soon for breast reconstruction. What about for the woman who is indecisive about whether or not she should do breast reconstruction?
If
What
there's
advice can you give to her
right,
to build her self-esteem at
if
that
there's
point in time? Mm-hmm.
well, the first thing would be if there's any doubt in her mind about the reconstruction, it's best to delay it,
Mm-hmm.
because we're doing additional surgery, which is important but not essential for her overall health from a cancer point of view. And there is always the option of a delayed reconstruction. So as I said, in certain situations it's best not to add the reconstruction, because it can, if there are complications, delay your overall treatment.
Okay. And what type of complications are normally associated with breast reconstruction? I know
Well,
the different types, so those complications must vary. Mm-hmm.
I mean, it's major surgery, so those
Yes.
complications, so bleeding, infections, blood clots moving to the lungs. Those are general, but specific complications, starting off with the implant, it's a foreign body. So there's a risk of infection of the implant itself, which can be treated with antibiotics, or if it does not, it actually has to be removed, even if it's almost at the end of the whole reconstruction process.
Mm-hmm.
It always, your safety comes first.
Indeed.
In terms of, it is a very expensive balloon. So the important problem is that, like any balloon, it can deflate or rupture. And if the overlying skin is not healthy, it can
Mm-hmm.
come to the surface and become exposed, which would also mean removal of the implant. In terms of the
Mm-hmm.
moving of the abdominal fat, it's basically we kind of do a modified tummy tuck. So that's the plus side, even though the recovery is going to be longer. Um, the fat which is transferred can lose some of its blood supply
Mm-hmm.
and develop something called fat necrosis, where certain areas are quite hard in comparison. And if it gets hard, then we have to just confirm that it is fat necrosis and not the tumor coming back in the post-operative period. But the other specific thing is that because we're usually taking parts of the muscle, there's a risk of a hernia formation
Mm-hmm.
over. So your recovery needs to be very guarded, especially over the first 6 months, to ensure you don't get a hernia. So, with the additional scars, there's always risk that a scar may not look as great. But the real big problem is that the balance of the non-affected breast to the reconstructed breast can be challenging. In prosthetic reconstruction, we're really trying to balance you looking very
Yes.
volume
Even.
volume in a bra,
Mm-hmm.
because there's no way that even if I do a breast lift on you to match you, it's not going to stay in the same place that the implant reconstruction is. So it is to match you in clothes more than match you out of clothes. And to a lesser extent, with the autologous or using your own tissue. But the reconstructed breast generally looks much better than the the natural breast, because it tends to have a little bit more youthful appearance.
Okay. For the procedure where the muscle is used, which part of the body is the muscle usually taken from? Or
It's
what are
one
the
of
functions?
it's one of your six-pack muscles.
Okay then. Okay.
So for your day-to-day person, unless you're very athletic, it really will not have an impact on your core strength.
Mm-hmm.
They've had many studies to show, people have a day-to-day functioning quite fine. I've done bilateral, meaning both breasts being done. That means both core muscles are taken on very active individuals, and they've managed to modify
Mm-hmm.
and you do lose core strength, especially with a bilateral. So usually, if you're doing both sides these days, I'm more encouraging the use of the prosthetics rather than a bilateral, unless you are very averse to using prosthetics.
Have you come across any patient or patients who are very high risk? For instance, they have the BRCA gene and have done a prophylactic mastectomy and have had to then do breast reconstruction thereafter
But we've
in
been doing a lot.
Jamaica.
We've
Mm-hmm.
been doing a lot of bilateral breast immediate reconstruction for that very scenario that you described.
Mm-hmm.
Yeah. So we've been doing that for quite a bit of time now. It's definitely it got more popular after Angela Jolie kind of popularized it,
Mm-hmm.
or not popularized it, but made it aware that she
There,
got
yeah.
it done, right. But there are, as you know, scientific tools to assess your skill, your risk.
Yes.
So, but a lot of people will opt to sometimes, even though the gene is not found, that to do a prophylactic on the opposite side.
Mm,
That makes our life a little easier because matching it can be a little bit simpler.
yes. But just for those who are coming from a strong family history of breast cancer and might possibly want to do that genetic testing, do you by chance know the cost for patients who have actually done that testing here in Jamaica?
I can't tell you the cost offhand, but what I can tell you is that the costs have significantly fallen in the last couple of years, and the amount of genes tested are greater. So, genes which we're not aware of, which can cause cancer over the next years to come,
Mm-hmm.
will more and more. I mean, in the past, when we were in medical school, we used to just say breast, ovarian, endometrial,
Mm-hmm.
all linked because of the hormone. But now, we don't take that history alone. We ask about other cancers in the family as well.
Yes, because they're also linked. Yes. Since we're on the topic of cost, what is the average cost in the private system for a unilateral mastectomy and a bilateral mastectomy?
That I cannot tell you off the top of my head.
Sorry, not mastectomy, I meant to say. I meant to say unilateral breast reconstruction. My mind was on mastectomy and bilateral breast reconstruction. Of
Right.
course, based on different techniques, yes.
Um, I cannot give you an accurate number off the top of my head,
Uh-huh.
because it depends on a lot of different things.
Mm-hmm.
Because breast reconstruction is multiple stages. So it's not a one-shot deal in most situations. So that's the first thing that I emphasize on with patients, that
Mhm.
it sure, we can probably get major 90% of where we want to get it to in one operation. The prosthetic reconstructions is generally staged, but the problem is that that second stage does require you coming back to hospital. It's not an office procedure, but it's an outpatient procedure. So most reconstruction second phases, third phases are all outpatient procedures and sometimes can be done with sedation rather than a full anesthetic. And I think more importantly is that the insurance companies have been covering reconstruction. So it's not an aesthetic operation. They understand the importance of it. And, depending on how good your insurance coverage,
Mhm.
certain patients have had complete coverage of their procedure.
Okay. All right then. I know the different types of mastectomies, and in some cases, a nipple might not have been spared. How does
Mhm.
one go about when reconstructing that breast to make that breast look as natural in terms of giving the impression that there's a nipple there? Is that
Right.
something that's possible?
Yes. I mean, there are different ways to do a nipple reconstruction. It's
Mhm.
probably the last step. I'd say it's kind of putting the icing on the cake, so to speak.
Mhm.
Um, it's using either two basic techniques. One is either using tattooing to create the illusion of a areola,
Mm.
and then the projection of the nipple itself is usually done with uh, creating small mounts of skin. Problem with that is that the projection does not stay up. Over time, it does, flatten quite dramatically. You can get a skin graft to create that darker areola instead of the tattooing as well.
Which part of the body does that skin come from?
Usually the
Sorry, usually the what?
inner thigh,
Oh, the thigh. Okay then.
the inner thigh.
The inner,
So,
oh, the inner thigh.
so the scar is fairly well hidden.
Mm-hmm.
The color is a little darker, so that's why we use that area.
Okay. You mentioned there are different phases of breast reconstruction. I gather the nipple reconstruction is the
Final.
last phase.
Yes.
What's the time interval? Well, can you make it clearer what each phase is and what's the time interval between each phase?
But that time interval will vary based on what the cancer treatment is going on.
Okay
So
then.
it's not really fixed per se. I mean,
Okay.
phases are much more important when you're doing prosthetics. So the first phase, we do the mastectomy and put a temporizing implant in called an expander, which allows you to fill to the size you want over several weeks. But
Mm,
generally, that will take 2 to 3 months to do, and then you can do the final exchange. But sometimes you do need chemotherapy and radiation therapy in between, and that can stretch out that time period.
okay. Okay.
And then with the implants, every 10 years, you've got to change out your implant because
Every 10 years.
even though we call it a permanent implant, it's not really permanent. It's like permanent hair removal, it's just for a long period of time, but not truly permanent.
Mm. So a major surgery every 10 years
Yeah.
for the lifespan person. Um, is the implant safe during
Well,
let during chemotherapy or is it
I mean, we talked about it being a foreign body.
oh no?
So with chemotherapy, you're immunosuppressed, meaning your immunity is down. So there is a higher chance of potentially developing infection in there. But it,
Mhm,
even though it's very small, but it can happen.
mhm. And I gather for
If
persons
there's
who had fat exchange, that it will be safe, having that type of breast reconstruction is a little bit safer during chemotherapy than an implant.
oh, definitely, as well as radiation.
Yes. Okay then.
So for both, but the important thing to mention, extremely rare. It was the biggest thing before COVID hit on the news, but there was a very rare type of lymphoma
Mm-hmm.
uh, that was associated with certain types of implants, and a lot of implants were taken off the market. So that was the biggest news to hit in the late um, to 2019.
Mm-hmm. Probably we should go into the different types of implants right now, just to educate
I
women who
mean,
might want to read and so forth.
right. So the implants broadly can be saline filled or gel filled. Both of them will have a silicone shell.
Mm-hmm.
So all implants will have a silicone shell. And the saline is salt water, which is 80% of your body. And silicone gel is what they call the gummy bear. So that's what they push in the media, saying that it's, more natural feeling, less wrinkling. So that's the main difference. So if you have a leak, if it's saline, it's absolutely safe, right? Because it's your natural composition. But
Yes.
if silicone leaks, then it's advisable to change that.
And what are the signs that are usually there to indicate that there is leakage, particularly from a silicone implant?
Not much sometimes,
Okay.
not much. It might be just detected on screening. But if you
Mm,
have a volume deflation, that would be the simplest.
okay. You said screening. So these patients, after getting implants, I know you said every 10 years the implant is changed, but in between those 10 years, not in between, yes, in between those 10 years.
So just like a regular woman, they need to have monthly screening by their self breast examinations, as well as imaging.
I didn't get the impression that a mammogram can be done in a breast with an implant. I don't know why. I didn't know that was possible.
Can be done. It just requires special adjustments from the technical side.
Mm, okay. I'm also thinking of the pressure applied by the two plates and the implant rupturing. I guess I'm allowing my imagination to go wild, but I'm just thinking of all of that. So it just didn't occur to me that that was possible. And also given the fact that it's not real breast tissue, I didn't know
Yeah.
cancer could reoccur in that.
But the problem is that it's impossible to remove every breast cell.
Mm,
So
yes. Okay
that's why
then.
you need.
Okay, gotcha. For a woman with breast cancer, I don't like to say breast cancer woman because a person's disease shouldn't define them. But for a woman with breast cancer who is looking or who has finally decided that she wants breast reconstruction and is looking for a plastic surgeon to do that procedure, what exactly should a woman consider when choosing a plastic surgeon?
Well, it's a team. So usually the general surgical person who's doing the mastectomy will have, will have that discussion with the patient
Mm-hmm.
and, and guide the patient. So there are more than, six plastic surgeons, actually more closer to eight now. So it is possible that different people will have access to patients, no matter which side of the island you're on.
Mm-hmm.
We're unfortunately not in the central and other areas, but we are definitely represented in the West as well as in Kingston.
Okay then. Are there any cautionary measures that a woman should take in place when having implants in? Any particular cautionary measures?
I mean, to be wary of any changes that occur in the breast
Hmm.
naturally would be the main thing, and obviously to avoid trauma.
Hmm. What about any lifestyle changes? Um,
Not necessarily. I mean, once you do implants for cosmetic purposes, there's usually not too much of a issue with your day-to-day lifestyle.
okay, then. There was something that I came across when researching on this topic, and it was a breast cancer survivor in one of, I can't remember, one of the states in America. And for her, some months after her mastectomy procedure, she couldn't look at herself at all in the mirror because she just wouldn't feel confident and she was sad. So for her, she didn't do breast reconstruction, but what she did was to tattoo a bunch of roses across her chest. And that helped her with the confidence, with her self confidence. And then she could now look at herself in the mirror. Um, have you come across patients like that who
Well,
maybe in the beginning were in the breast reconstruction and after it change their
yes,
mind and did tattooing?
definitely. Well, not tattooing, but change your mind and had the reconstruction. You know, it's an implant, so you're taking them out. You know, taking out the natural breast tissue is a lot more difficult. So that's happened, but it's more likely to that decision is made well beforehand. So
Uh-huh.
right, so less than even in the States, less than 30%
Hmm.
of women really proceed to reconstruction.
Less
So
than 30%?
yes,
Okay.
so and it is actually a federal mandate in the States that any person with breast cancer should be referred for counseling for reconstruction. So
Hmm.
it is, I mean, what I can tell you is that surgeons in Jamaica have been a lot more following that mandate. So we get a lots of reconstruction consultations, but like I told you, there's a large amount who do not reconstruct after counseling.
Yes. Because I mean, that's a big surgery, changing a certain part of your body. And
Right.
that requires, I mean, some sort of counseling.
Yeah.
Do you or have you noticed that for some women, their partners have an influence in their decision to have breast reconstruction? Has that been
Well,
a major factor?
I can tell you that the partners generally are very supportive of
Mm-hmm.
whatever choice that they make. And they would actually, majority of partners would prefer they didn't do the reconstruction because they're, they realize they're adding another layer of risk onto their decision process. So it is something that, they have not usually demanded that they must get reconstruction. It's actually the opposite.
Okay. I'm so okay. I'm pleasantly surprised. The reason I'm surprised is because throughout the organization of this breast cancer awareness series and speaking with some of the breast cancer survivors, their relationships have not survived the journey. And
Unfortunately,
sorry?
that is unfortunately, that may happen.
Yes.
I think the people who talk about it are fortunately less in number than the people who are fine, so the people who, so you'll have a biased population that may have, but generally it is not that case. I mean, the women have a great deal of difficulty adjusting even with the reconstruction because it's not exactly what they planned or imagined and it would look like. And in some situations, we're in a better place than where you were before. But there are others where you're not matching par with what their expectations are.
So
So
what? Oh, sorry.
that in turn creates personal problems within their minds, which can hence impact on their relationship with others as well.
Mm.
So it is, but generally, I tell you, those majority of, there are very few partners who I know in my group, small group of patients who have left because of the diagnosis.
For that same group of patients, has any of them maybe brought awareness to breast reconstruction after breast cancer, or is it something that is hush hush that they don't really speak about in general,
Well,
publicly at least?
no, I mean, every year, Cancer Society, since, I mean, for over 20 years now, we've been, every October, we've been talking about reconstruction on their platform. So, yeah, I think even before you started medical school, probably that platform up there, right?
Okay then.
So it's just that generally a lot more media is available for everything. So, people are more aware that these things are available, but it is not, it doesn't work out always because unfortunately the hospitals do not store implants because they're expensive. And, patients who want to do it and unfortunately will have to find funds to, even though through the hospitals, they get it, the reconstructions done
Mm-hmm.
potentially, under the Health Care Act. So, but they will have to get the additional material if they require it.
The implants.
Yeah.
And I'm guessing that's a cost that you can't really estimate for me, just for a woman who
Well,
might be
that's,
interested in
yeah,
doing.
so like the expander itself can be about 110,000 Jamaican, and the final implant, depending on the saline or silicone. The silicone, if available locally in the size you want, is actually cheaper. Might be half the cost of that expander. But the saline is more expensive because it has to be special ordered and flown in, and
Mm.
that that can easily for a cost of almost as much as that expander.
Okay. How can a woman go about deciding whether or not, what size breast for those who have gone through bilateral mastectomy and she wants to either go a size down or up and isn't quite sure? How do you go about guiding
That,
her through that
that's a
process?
that is a technical question that has to be answered with the individual in front of me. They will be counseled on what are the pros and benefits of going up in size or going down in size, or what I think is a safer size for them
Yeah.
to try to match. So those things are judgment calls between the surgeon and patient.
Well, thank you so much. Um, is
Thank
there
you.
is there any last advice that you would want to give to someone who has, let's say, just completed chemotherapy treatment, has obviously done her but let's say bilateral mastectomy, has completed her post-surgery chemotherapy, and is or has now decided to do breast reconstruction? Any advice for such a woman?
Well, I think the first thing would be going to mastectomies, doing chemotherapy. That alone are two independently huge hurdles that she has jumped over.
Mhm.
She definitely needs to give her body time to heal and her mind time to adjust, and then revisit reconstruction in a delayed fashion.
Okay then. All right. Thank you so much, Dr. Venugopal. I appreciate it. I appreciate your time that you spent engaging me in this virtual discussion on breast reconstruction. Thank you.